Good morning. Nice to see you all. Really glad to be here. When Steve asked me to come and talk to Breaking Barriers, I didn't really know what I was getting into, but I trusted Steve. I thought if he thought I'd have something to share, then that was probably a good sign. And I liked the name. It seemed like a good idea. I'm all about breaking barriers. And it was more than 3 months ago, and I'll say yes to anything that's 3 months out, it turns out. Yes, yeah, right. Make your requests now for February. So I thought I was going to start and dive into lots of information about building accountable communities, how sort of health is a place-based phenomenon, et cetera. But I actually want to start here. This is 20 years ago in the South Bronx. We've got New York connections. So I was a team leader for an organization called the City Volunteer Corps. I spent about 3 years, 2 years with this group of young people, running service projects and teaching high school throughout the week. So I want to start here for a couple of reasons. One, before I get all wonky and start throwing graphs and other diagrams and research up on the slide, I know there are a lot of people in this room who are much closer to direct service. So I wanted to, honestly make clear that I'm not just a policy wonk. I have some grounding in direct service and understanding of what that looks like, though I'm not a child serving systems expert by any stretch. Also, the hair. Man. I mean, this is actually like a month before this picture was taken. I had a ponytail halfway down my back. That guy has no idea what's in store for him, what's coming up. But most importantly, I want to tell there are a lot of stories that go along with this picture, but one of the big stories for me is sort of my own learning and development through this process. So I started out, and I thought, okay, I'm going to make connections with my team members. I'm going to really make it clear that I care, that I'm there for them, and I'm going to set really ambitious goals, and we're going to work together to achieve those goals. Most of these young people, almost all of them, either dropped out of high school. Many had been involved in the juvenile justice system. So they had some real. We had a year, 2 years to get. To achieve educational goals, to get job placements, et cetera. So I thought, that's it. I'm going to be very focused on these outcomes, and that's going to work. I'm going to make some real progress, and I'm sure you can imagine where this is going. What I learned was that their issues actually were not primarily educational or motivational. It was about the other stuff that was in their lives. Whether it was housing, ability to pay for basic services, and ultimately the accumulated experiences and family instability that they'd experienced. So I know what you're all thinking. I was learning about the ACEs pyramid. I didn't have the language to sort of think about it this way, but sort of what I was getting to understand, and what I had to reconcile was that my job actually was going to be less about tutoring in geometry, and it was going to be more about navigating systems, being willing to have somebody sleep on my floor when they had no other housing, going with people to court, and navigating all these different systems. And actually the best thing I did was that I started flirting with the social worker at the organization. So she would come out and visit my team at least once a week. So we could work through this stuff. So I started to sort of realize that the way I was intervening had to be more holistic. I had to look at a broader range of strategies. I came across this not too long ago from HealthShare Oregon. I think it's a really nice. They have this. They call it their chutes and ladders diagram. Right. And so the idea is that there are all of these different ladders at different stages of life, places where people can fall off a path towards stability, towards well-being, towards health, right? And on the flip side, there are ladders. They're these sort of building blocks, right? Each stage of life, you want to sort of build up. You want to build the parent relationship, attachments, readiness for kindergarten, et cetera, as you move up that path. So this is sort of where I went and started working in early education. And then at some point, I mean, this is the quick version of the story, recognize that this whole pathway exists in a much larger context, right? So I had this series of experiences. I was running a tutoring and mentoring program of going out to visit the tutors and mentors that I trained and placed in schools. And it happened in pretty rapid succession in a month as I did one set of these visits, hearing from the tutors and mentors how they were struggling with trying to get students focused on schoolwork when there had been a violent incident at the school or in the neighborhood recently. How to deal with the fact that a number of their students were homeless and didn't have enough to eat, and how were they actually supposed to get these students to focus on academic achievement when these issues were happening outside the context. So this is sort of an individual pathway, right? But this all exists within a broader context. So again, I didn't have the language for it really at that point, but we're talking about the social determinants of health. I'm sure many of you have seen this slide. I'm almost resistant to using it because the reality is if you sort of do the deep dive, there's not really any research behind this. It's put out as though it's a kind of research phenomenon. And I think the takeaway that everybody agrees on is that it's social and economic factors are the largest determinants of health, right? We're putting all of our resources kind of over in the access to care piece, but actually it's the social and economic factors that are driving health and social outcomes. And one way to think about this or to see this as evident is by looking at a map. So this is from the California Healthy Places Index. It's a great website, though you can lose hours, so be cautious as you go into it. This is Sacramento, for those in the back who can't see some of the details. And this is the overall index. So the Healthy Places Index is a composite score, looks at multiple indicators. But the basic kind of message of the index score is that it's life expectancy. So you may be familiar with this campaign that the California Endowment ran a few years ago, looking at how zip code is more important for your life expectancy than genetic code, right? So 2 different zip codes in California, one with a life expectancy of 73 years, one with a life expectancy of 88 years at birth. Dramatic differences. In some cases, you can see this sort of disparity within the same city, the same county. I live in Alameda County. You look at the Berkeley Hills and the Berkeley Flats, and there's almost a 20-year discrepancy in life expectancy. Right, so here's back to Sacramento. I don't know Sacramento all that well, so I can't say all that much about what's going on here. So the blue, bad, green's good in all these maps, okay? But you could do this for any county, and Healthy Places Index has data for every county. So I don't know very much, but I have a pretty good picture of what's going on, what's different between the blue and the green, right? I'm sure all of you do too. What do you imagine might be different in the blue communities and the green communities? Poverty, great. What else? Access to healthy foods, great. A couple more. Housing, yep, housing issues, affordability, access, great. One more. Safety, yeah, absolutely. So I'm not going to run through all of them, but let's look quickly at a couple more of these maps. You can look at all of these issues, right? So this is self-reported mental health, okay? So blue, self-report is not so great mental health. Green, very positive. Here's race. Green is white. Blue is very few white people. So looking at these, I'm going to flip through them quickly. If you look at that sort of oddly shaped green area in the center and then the blue shape up towards the top, you'll see that they stay pretty much the same. And I've looked at dozens of these maps, and it's the same, right? It's the same. And in some ways, that's not surprising, but it also really sends a message that what's going on here is not about individual people, it's about place, and it's about those social factors, the things that all of you started to list out. And I think we could probably have come up with a list of 35, 40 things that look different. And I find a good way to look at this and think about this is this is the BARHI framework. It's the Bay Area Regional Health Inequities Initiative. It's a consortium of health departments in the Bay Area focused on equity. Anybody part of BARHI? Are there any BARHI? I see a few hands, tentative hands. Very cool organization. And this is sort of how they think about the production of health and well-being. So, on the far right, you've got mortality, you've got sort of outcomes, and then you work back, there are risk behaviors which are influenced by living conditions, which are then influenced by institutional inequities, shaped by social inequities like class, race, immigration, so forth. So I think this is an interesting way to think about both how some of those patterns on the map get formed and also where to intervene, right? I mean, there's no right or wrong place to intervene on this pathway. In some ways, there's an argument for moving to the right because you can identify people more easily, you can target interventions more easily. On the other hand, you move towards the left and you're going to affect more people and potentially in a more enduring way. So this is one of the ways to sort of think about our work and where we put the emphasis. And you can apply this to a whole range of issues. Right? We can look at a map. We can look at this graph on the bottom left here is life expectancy at age 50 for women by economic status. So what you see, it's sort of a disaggregation. You've got, if you look at the population as a whole, it looks like life expectancy is slightly increasing over time. But when you disaggregate it like this, you start to see that actually the poorest women, the black line, are seeing a decline in life expectancy from age 50, right? This means you get to age 50 and you've got almost a 15-year discrepancy between rich and poor women. So rich women doing very, very well, and life expectancy increasing over 90 years, which is a pretty good outcome. We can also look at the way we define the issues. So on the top right here, we have the red lines are all kind of classic medical diagnoses, causes of death, right? Heart attack, stroke, lung cancer. But then these researchers also looked at the social factors that have sort of an equivalent impact on health outcomes. So educational status, income status, so forth. And again, it's this question about where are we going to intervene, right? I mean, if we thought about income inequality as having an equal impact on health as lung cancer, if we really thought about that, where would we put resources? Would we have a different sort of response if we thought of those two as sort of equal factors in determining health? And lastly, on the bottom right is one I think all of you know more about than I do, the rising suicide rate among adolescents in California, right? Nearly 50% increase. Scares me as a parent. And I think it's vexing. What's really going on here, right? It can't be that kids have changed, right? So if we think back to our BARHI framework, what is it? What is it in living conditions, built environment? What are institutions doing that's changing, that's actually leading to that increase? I don't have a good answer. I think we're still trying to sort that out. I think it's an important lens to bring to it. What are the underlying factors? I've had a chance over the last year or so with colleagues at JSI to talk to roughly 25 leading health thinkers in California. And this report, Untying the Knot, is about to be released, should be on our website on Monday, I hope. And what I heard from these individuals were a lot of incredible ideas and thinking, but to distill it down, there's agreement across the board on what we really need to do, or what the goals are for a transformed health system. Right? It's better health, better services, reduced costs, happier staff and stakeholders, and increased equity. You could call this the quintuple aim, if you want. The triple aim is the top three, and the the bottom two have kind of been added over time as important elements. And actually, those additions are really important because I think what people realize as they looked at that triple aim of better health, better services, reduced costs, is that you could get those three things and actually end up with less happy staff and clients, and you could decrease equity. It is actually possible to get those things. I mean, a really easy way to do it is just start restricting services to some people, right? Kick them out of the pool, right? You'll get better equity. If we just eliminate low-income people of color from our service pool, we will get better equity outcomes. But that's not our goal. And you will probably end up with less happy staff because they will see the inequity of what's happening. There are lots of ways to think about that. But so that's sort of like there's consensus, there's agreement, this is what we need. What there's also agreement about is that there's no one who's truly accountable for those goals, right? There are different entities that see some piece of that, and you could see healthcare potentially really feeling like they have some accountability for the cost and the service piece, but not much accountability really for better health in the end. We'll talk a little bit more about that. And certainly not much accountability for equity. So it's really this landscape in which accountability is not well defined or well held within the system. So I want to talk about three kind of prescriptions that came out of these discussions for how to deal with this accountability issue. The first is about how we use money. So there's a great book and series of studies that folks out of Yale and Harvard did called the U.S. Healthcare Paradox. I think the book is called The Healthcare Paradox. And one of their key findings is that when you look at spending across developed countries, what you see is that, I mean, one, we know the U.S. spends more than twice as much on health as any other developed country. But actually, when you look at the sort of portfolio of investment, you see is that the actual spending isn't that different. What's different is that in the U.S. we spend money on healthcare and not so much on social services. And in other countries, they flip that, right? In other countries, it's 2-to-1 social services to healthcare. In the United States, it's 2-to-1 healthcare to social services. So there's this sort of, there's a portfolio of investments issue. And I know I've had education people tell me you could do the same graph with education and criminal justice, right? You see the same sort of ratio and flip. I see heads nodding, so I'm going to take that as added confirmation that that's true. So actually, as Daniel was mentioning this morning, we are seeing within the healthcare sector some response to this, and the response is, oh, social determinants of health. Oh, right, okay. As we, as healthcare entities, have more responsibility for controlling costs and improving health, we recognize there are all these things that are happening that are affecting our members' health and our bottom line. So great, social determinants of health. So actually, we also, in the last year, have interviewed most of the managed care plans, we didn't get to in California, about social determinants of health. And what we hear is they're all making investments, right? 84% of them say they're investing in housing, 79 in transportation, 74 in food insecurity, the list goes on. Basically, all of them are making big investments. And so part of it is this recognition of social determinants. The other piece is that managed care plans actually have a lot of money. They made a lot of money off of Medicaid expansion in California, and they need to move that money and expend it. So they're actually making unprecedented investments in social determinants. So this is actually my little plug. If you have a relationship with your managed care plan, go and make some asks because they do have resources to spend. And we can talk more about that. Come to the deep dive. We'll talk more about it. But I have the same concern that Daniel expressed this morning of medicalizing these social issues, right? And I think one of the big distinctions to draw is everybody uses the term social determinants of health, right? It's sort of this catch-all for like anything that isn't in a clinic, one-to-one service delivery. There's a real distinction between giving a specific prescriptive service to your member that relates to some social need. So, for instance, giving them a voucher to take a lift to a medical appointment. Well, the health plans would call that transportation investment in social determinants of health. It's pretty narrow, right? It's really, we have to come up with some category. People are starting to talk about this as social needs, right? Or social care. Right? On the other hand, there's, right, I mean, I've done some work on land use and transportation planning, and there's a host of issues that the individuals that Medi-Cal managed care plans serve related to transportation that have to do with public transit access, street safety. There are a number of health plans also that have invested in bike sharing. Bike sharing is a good strategy, but it's not really applicable in a neighborhood where the streets aren't safe and you can't even get to a public transit hub in order to connect your ride from home to work using bike sharing. So there's all these other issues. So there's the narrowness, right? This sort of distinction between social needs and sort of true systems work on social determinants of health. And there's a host of kind of, I think, economic issues here too. Who's going to control those dollars, right? Is it the healthcare institution, or are they actually going to partner with folks like those of you who are in the room to do this work on the ground to address social issues in a way that actually shares the money and the power? The other thing that I want to talk about in terms of money is pervasive wrong pockets problems. So this is kind of this notion that somebody makes an investment, some institution makes an investment, dollars, time, et cetera, in solving a problem. Somebody else benefits. So a good example that comes up a lot now is around housing. So if a housing organization invests in housing an individual who has significant social and medical needs, you're likely to see a reduction in medical costs. How do you recoup those costs? Right? So the health plans are sort of starting to get this and trying to figure out how do we invest in housing in a way that actually is sort of more equitable and supports those sorts of investments. But these problems are pervasive. A really great example that I like to cite is tobacco control in California. So great success, right? National model. Analysis was done that tobacco control efforts in California saved roughly $134 billion in healthcare costs. It's a lot of money, $134 billion. Anybody in this room get any of that money? Anybody? A little bit? Good. Nice. From the taxation or from the healthcare system? Yeah. Okay, great. So there was a little bit of funding that was generated, but it was really from taxation on cigarettes. The healthcare system, I don't know where that money went into the system. So how do we actually get that? I mean, imagine if at the beginning of that tobacco control effort, if there had been an agreement brokered that said, okay, you know what? Public health and children's health services are going to get 10% of any savings from all of this. We'd have $13 billion. We'd have the largest health foundation in the country funding all of your efforts. So how do we actually close some of these loops? I imagine if you think about it for a second, think about something that you're working on that somebody else benefits from. Can anybody think of anything? Anybody got an idea? See some nods and hands. I can think of dozens of ideas. So, part of that's natural, right? There's always going to be this crossover. But when we get to these sorts of big shifts in impact and capital, how do we actually kind of close some of those loops and acknowledge some of the benefits, particularly when you're doing upstream and prevention work? I want to talk about this one other example quickly. So the picture on the right here is probably a little hard to see in the back. This is an intersection in downtown Oakland, Chinatown in Oakland. So, and if you went down this street sort of all the way to the right, you'd see Asian Health Services, federally qualified health center that's there. So roughly 15 years ago, the father of a member of the Asian Health Services board was struck and killed by a truck at one of the intersections right near here. And it raised this issue of transportation safety. So Chinatown and Oakland, large elderly population, a lot of children, a lot of individuals with limited English proficiency. And they looked and they saw that this area had one of the highest rates of traffic injury and fatality in the state. Not surprising, right? This is really wide streets. You've got the Port of Oakland kind of right on the edge of this, tons of trucks. You've got timed lights, so trucks are sort of barreling through this community. So they got engaged. They sort of partnered with a bunch of different entities to try and do something about this. Came up with a bunch of strategies. This is one you'll see if you're there, these scramble intersections. So the lights turn, you can cross in any direction. Most of the lights are really long pedestrian crossings. Change signage. There were a whole host of strategies. They got a bunch of youth researchers involved who monitored change over time, and they saw roughly a 50% reduction in injuries and deaths within a couple of years. Right? Such incredible work. So I heard this story from a pediatrician at Asian Health Services, and I was like, this is it. This is great. Look at this example of a healthcare entity getting involved in their community, making meaningful community change. I said, great, what are you going to do next? He said, well, we're really struggling because we can't pay for this stuff. I said, what do you mean 50% reduction in injuries and deaths? There's got to be some way to pay for it. He said, no, that's the hospital. That's the hospital. We can't access that money. We have no way to recoup any of this money. So we're surviving on grants. So if we can find a grant to do additional community engagement work, we'll do it. Otherwise, we have no funding stream. So again, it's back to this issue of wrong pockets. I mean, this is even just within the healthcare system, right? How can it not make good sense for a community-based healthcare organization to do this kind of work that has meaningful, and this is short term, right? The issue is often like, well, we don't want to do that stuff because it's going to take 10 years. This was 2 years. And really appreciable cost. You can put a dollar figure on all of that. Next issue I want to talk about is complexity. So this is impossible to see, which is fine. This is the MCAS, the Managed Care Accountability Set for California. It's the first page of it, actually. There's about 6 pages, I think, of metrics here. So the first thing, I don't know a huge amount about healthcare quality improvement, but in the last year I've kind of started looking at this a little bit. The first thing is there are a lot of them, right? 6 pages. Really hard to assess what's going on. It takes actuaries and auditors years to even figure out performance within the system, right? So that's the first thing. There's so many of them. It's so complex. The second thing you see looking at these is that they're primarily about internal health care system functions, right? Which on the one hand totally makes sense. This is the healthcare system. They have certain processes. We should measure them. But the bottom line there is that they're actually not really about health. There's almost no monitoring of improvement in health here. What there is monitoring improvement in service delivery. And those are 2 different things. Not that they're not disconnected, but they are different. And the third, and related to the second, is that there's no prevention. There's no monitoring of prevention. It's all focused on individuals who are already diagnosed with a condition. So for example, one of the measures is the only asthma measure is about medication adherence, which is fine. I mean, medication adherence is an important thing and it should be a goal for a health plan. I'm lucky, nobody in my family has asthma, but I know a lot of people who do wrestle with it. And parents who wrestle with asthma, medication management is one piece of it, but it's not their priority, right? They would much rather their health plan be concerned with their children not having episodes of asthma than that they're taking their medication. And they'd much rather their health plan was thinking about clean air in schools and in communities in their houses, et cetera. So the medication management indicator pushes a certain set of strategies, but actually it may not be the right strategies. I've been excited to see that there are a number of efforts around the state to change the scope of Medicaid quality measurement. So this is one example from Oregon where they are experimenting with kindergarten readiness as a measure for their managed care plans. It's a radical idea, right? That healthcare would actually have some responsibility for kindergarten readiness. And from what I understand, it's been really hard to figure out. I mean, because the first thing that the clinical institutions say is like, well, what do we have control over? All right, well, we'll do immunization rates and we'll monitor motor skills. Like those are things we can sort of do. But they're already doing that and doing a reasonably good job about it. Where it gets interesting is where you really push and say, no, you're accountable for whether or not children are kindergarten ready. Right? We're putting a lot of money into you, managed care plan, to serve children 0 to 5. So think more creatively. What can you do to actually improve kindergarten readiness? And it changes the conversation, right? It starts to set tables like all of you are sitting at with a health plan there saying, okay, now we're serious. Now we really care about what you're doing because we're going to get paid if we can all improve kindergarten readiness. The next piece about complexity that I want to talk a little bit about is some work we're just starting on with funding from Genentech's community giving. Thinking about sort of what do we know about the state of what works for childhood adversity. And we're pretty early in thinking about this, but looking at strategies and how we measure impact. And one of the first things that we came up with and realized was that there is so much interrelated language being used, right? I mean, this is just a partial list of the terms, right? And that makes it really hard to even figure out which research to look at, who to talk to, and more importantly, right, how people on the ground are thinking about these issues in a coherent way. So again, and I would love to have conversations with folks in this room who have probably thought about this more than we have. We started to try and discern, who's using the terms and who do they resonate with and why are there so many terms, which ones are connected to each other. So one quick hypothesis that we've come up with that I'm going to share is that is recognizing actually that there are certain people who benefit from this proliferation of terms. And we're kind of some of those people, right? You look at the terms and there's a line from every term to researchers. There's a researcher who is making a career out of every single one of these terms. And we just need to recognize that as a sort of consultant and researcher, I will get a lot more traction saying, hey, I have the new term that's going to answer it, than saying, you know what, they have the good term. I'm going to help them research, right? I think that's part of what's going on. And I'm sure we could actually do a little exercise where we put people's names to these different terms, because I know some of the researchers who have created these terms and are making some hay out of that. So I think that's an important piece to recognize, that there is, that drives the conversation. And the other place that we see that driving the conversation is in terms of how different words are being used. So this is a great little bit of research that my colleague Erin, who's sitting over here, did looking at use of terms in California legislation. So what you see is this really big spike in the use of the terms ACEs, for instance. Not surprising. I think we can all kind of imagine what's happened in the landscape to create that change. And that's great in some ways, right? There's increase. I mean, we want to increase attention. But it raises some real questions. So, I mean, one, why are all these terms still being used separately? And what does that mean in terms of the legislation? All four of the terms that we see used most frequently are characterizing a problem, not a solution. So what does it say? Do we actually know what to do about these things? We're writing a lot of legislation because there's an increase in attention, but do we actually know what to do, what the response is going to be here? And the answer is partly, right? We're going to start screening a lot of children and people, but where does that lead? So it's an interesting question in terms of complexity. How do we reduce complexity, get to a more coherent picture of what's going on? And the last thing I want to talk about, and I don't have as much time as I hope to talk about it, but it's really, I think, most relevant to all of your work and why we're here, is about a different kind of infrastructure. If you sort of buy my argument that health is about place, it's about social factors, it's about getting smarter about how we use money and how we focus our efforts, then I think the reality is we need a different kind of infrastructure to do this work. And I'd say that infrastructure involves these 5 elements. A neutral, trusted convener, who has the time, I should put that up there actually, it's critical, who has the time and resources to play that role, right? My guess is that there isn't anybody in this room who is given a lot of time to actually facilitate the alignment of efforts with the other people at your table. So resources for that neutral convener who's accountable to all stakeholders, or it doesn't have a vested interest, but actually is accountable to all stakeholders, including community members, focused on efficiency and coordination, right? There are lots of gaps in services. We can actually get a long way just by better aligning and coordinating what we're doing. Has the ability to pool and align dollars. This is actually really key, right? They have the authority to actually move money around and broker deals that track resources in ways that get to that kind of coordination and alignment. And lastly is really centered on equity. Keeps that front and center, which, I think equity is often kind of thrown into these conversations, and I do have it at the bottom of the list here, but it's critical. And my experience in working with a lot of these collaboratives is that it's easy to say and really hard to do and operationalize. How do you actually do that? And how do you get, particularly some of the vested partners who hold a lot of the resources, to really commit to improving equity? So thankfully in California, we have some really great examples. And I'm going to talk a little bit about this one. I should say, so JSI is the sustainability and financing technical assistance provider for CACI. So I have my own vested interest here. But I think it's a really great model of how to implement those sort of 5 components. There are other models too, so stay focused on sort of achieving those. But CACI is taking place across the state, so there are 13 sites. Many of you are probably in some of these counties. It's funded by 7 funders, so that's actually in and of itself a great advance. Funders put their money into a pool to fund this. And it's part of a national movement. This is actually, this notion of sort of accountable communities for health is taking off across the country. And in essence, it's kind of 2 pieces. One is there's like a leadership component. So this graph on the left, and bringing together these different pieces. There was a lot of discussion about data sharing and analysis. The Wellness Fund is the resources. The portfolio of interventions or strategies. Resident participation and leadership. This kind of backbone support. So that's the kind of aligning function, paying somebody to actually do the work of building the collaborative. And having a shared vision, being really clear about what the goals are. And on the other side, this is actually this little diagram, which is probably almost impossible to see for most of you, is Sonoma County's portfolio of interventions. But it's just to give you this notion that part of the strength of an accountable community for health is building strategy that involves these different components at the same time. So bringing in clinical services, community programs, this upstream more policy and systems work, and a sort of linkage component where, for instance, referrals are made between clinics and community organizations effectively. And then it's really the power of putting all those things together in an aligned package that gets us the outcomes we want. Right? And I think we can think of lots of examples of where that's been the case. Tobacco, again, is another really good example where it really took activity in all these domains to move the needle. Right? We did clinical services for a long time, didn't get us very far. It wasn't until we put those other components in place that we saw a significant shift. So I'm going to go really pretty quick. There's really good evidence building for this, so if it's useful to you, which maybe in making the case for your own activities, there's been some good recent research around this notion of collective impact and how it actually has shown some significant movement on issues like teen birth rates, youth justice involvement. So really trying to build this infrastructure can actually get to those outcomes. And some broader work looking at kind of collective capacity within a community. What does he actually call it? It was the strong multi-sector partnerships, and that is very closely aligned with reductions in mortality rates within communities. So I think we can point to, although it's still evolving, some really good evidence. And there's some really good practice examples from both some of the California catchy sites who've demonstrated by doing this kind of multi-part strategy improvements around asthma, blood pressure, coalition in New York that's worked on opioids. So if there's, there are tons of these examples. So if you sort of need to connect the dots between an issue you're working on and an example of success, let me know. I can find those for you. How much time? I have 1 minute? Okay. All right. I'm going to tell this story super quick because I think it kind of pulls it together. About a year ago, as part of my work with Catchy, I hosted, along with Catchy team, a roundtable trying to match up the Catchy sites with private capital investors. So community benefit people, FDICs, other impact investors from foundations and other sources. And I got two communities. I had to work with two communities to get them to give what we ended up calling a guppy tank pitch. It wasn't a Shark Tank. It was going to be friendly, so it was guppy tank. One of the communities was Imperial County. So we started talking about what was she going to pitch. And she said, well, I could pitch this stuff about housing remediation. We want to do a bunch of housing remediation to reduce asthma. We could use some capital. But she wasn't that excited. I was like, well, think about it a little bit. Come back to me. We'll talk in a week. She came back. She said, you know what? The housing stuff's not that exciting. I've got money lined up to do that. You know what I really want to do is get into geothermal. So it turns out Imperial County has a Salton Sea. Salton Sea has receded. The dust is one of the big causes of asthma in the county. And the Salton Sea also happens to sit on the most active geothermal site in California. And there are all these companies coming in wanting to build plants. She said, so I started to think about this, and I went to the Board of Supervisors, and it turns out all these companies are trying to get deals brokered with the county right now. And so I told the board, like, we should demand that they invest in remediation of the lake bed and housing in the county. And the companies came back and they said, great, if it'll help us get the contract, we'll put a set aside for remediation and investment in housing into our contracts. We'll do it. And I thought, it's such a great example of sort of bringing these different pieces together, right? Use the funding differently. Look, where is there money in the county? Let's cut through the complexity. What do we really want to do? We want to remediate the lake bed, and we want to get people safe housing that doesn't cause asthma. And it's about the infrastructure and having this sort of leadership who has the capacity to actually go out. And part of it is just that she's a respected leader, but part of it is that we have this sort of structure that says part of our work is about brokering these cross-sector deals. So she has the capacity to go out and talk to people and identify where there's a deal to be made that will actually have impact. So that's it. I'll close there. Thank you all. There are a bunch of resources that we've put together that I'd be happy to share with all of you. And if you want to join our newsletter, that'd be great. We only put it out quarterly, so we won't inundate you, but keep track of things. And we also will have a deep dive session to go deeper into anything that I've talked about a little bit later. So thank you.